Dr. Machado, for that kind introduction, and let me begin sharing here. We'll make sure that works. Okay, it looks good from my end. Hopefully it looks good to you. And I will try to open up the chat here so that I can see. Here we go. Great. Yeah, so please feel free to jump in and offer any questions or comments as we go. But I also do have the chat open here in case anyone would like to offer comments that way. So again, it's a great honor to be invited to present to you in such a wonderful project that I understand IMPERAS is, and thanks again to Dr. Machado for this invitation. Hopefully this is the first of many interactions I have with the group there, and great to see so many folks on the call. It's really quite an honor, and also an honor to share the session with Dr. Linos, who I haven't met until today, but with an esteemed co-guest there. I have nothing to disclose, but I hope that you do enjoy this case, and this case is one that we did see at Stanford in the past couple months, and I'm presented to you without any tricks, really how we did see the case. I know something is a bit lost when we present things remotely, but hopefully you enjoy the case nonetheless through this format. So this case was, interestingly, a newborn female that had a visible right leg abnormality at birth. In terms of the history, this is a term pregnancy that had no complications. The prenatal screening, including anatomy scan, was without abnormality, and there was no reported family history of malignancy in this patient. You can see here on physical exam, this patient had a visible right leg swelling. It was described as vascularized. It was noted to be tender to touch, and there was a clear leg length discrepancy in this newborn baby. So jumping already to imaging studies, initially an ultrasound was performed that identified a mass, and then subsequently an MRI, which I'm showing to you here. I'm not a radiologist, but I'll describe to you a 7.3 centimeter mass that really seemed to fill the proximal right leg, the thigh of the right leg. You can see here it was ISO to hyperintense on T. Yeah, so I hope that question was for me. Unfortunately, I don't speak Spanish, so appreciate if that question was for me. Yeah, apologies if I don't understand. Anyway, this is a ISO to hyperintense mass on T2, and then with the administration of contrast, this was diffusely contrast enhancing. I'll point out to you, in addition to the marked size of the mass that was really filling the thigh compartment, there was this peripheral rim of what appeared to be increased contrast enhancement, and the mass was actually centered on the femur. You can see here on the sagittal view and on the axial view, and it was actually felt by our radiologist colleagues that by imaging, it appeared most likely to be originating from the femur and then obviously extending quite markedly into soft tissue. So a core biopsy was performed, and again, hopefully I've imaged this well. Part of the interesting aspect of this case is perhaps that it's not the most ideal biopsy. You can see some folds in the tissue, so I apologize for that, but this is kind of the real world demonstration of what we were seeing here. So a core biopsy, a single core in this young patient, but hopefully you'll be convinced that it was ultimately an effective diagnostic core. So you can see here variably pink and blue areas, so reflecting heterogeneity in the density of cells in this mass. At this low power, architecture is sort of ill-defined, and there's not really a prominent vasculature again at this low power. I do want to demonstrate to you sort of the interface with surrounding normal tissue. You kind of see a rim of atrophic skeletal muscle here, and we'll come back to that as it's relevant to understanding this mass. And then it abuts here really the dermis right away. So you actually have skin overlying this mass as it approaches skeletal muscle in between there. So jumping down on a higher power here, I think you immediately appreciate the spindle cell cytomorphology that dominates this tumor, some collagen in the background that we'll see as we continue here. And I think as an architecture, I described this, we felt like this was sort of short fascicles that were arranged quite haphazardly, almost a story form architecture, I think, captured in this, maybe some extravasated blood in the background here. A more hypercellular area of this tumor, quite high cell density, some blood in the background again here, Again, that short fascicular architecture. Cells, we'll go down on higher magnification here to understand the cytomorphology, but you begin to appreciate that there may be some hyperchromasia, so fairly dark nuclei. And here again, you can kind of see those fascicles here aligned more in sort of what we might describe as a herringbone fascicular pattern. Again, some hyperchromasia. Overall, the chromatin is quite evenly distributed. You maybe see one or two nucleoli, but the cells, the dominant appearance of the chromatin is quite even, quite hyperchromatic. This was a unique view where the cells did appear somewhat vacuolated. There's some cytoplasmic vacuolization. I don't think anything that reached the level of obvious, lipogenic differentiation. And overall, I would say that there were not features that clearly demonstrated the cytodifferentiation of this tumor. You can see quite a bit of fine collagen in the background in the more hypocellular areas. And again, I would argue that the vasculature in this tumor was overall sort of inconspicuous, did not have a clear, distinctive vascular component. We'll go back to this interface with skeletal muscle just because I want to make sure that's apparent to everyone in terms of understanding the sort of growth potential of this tumor. The tumor does appear to sort of abut this muscle in a somewhat infiltrative way. You can see here the muscle on the left side of the screen, and then infiltration of skeletal muscle fibers, background skeletal muscle fibers that are, of course, atrophic. And here again, on very high power, you can see that tumor infiltrating through the skeletal muscle fibers in the background. So that's sort of the morphology. At this point, I'll leave this more for the discussion with the group, but I'll offer, admittedly, quite broad, almost silly, kind of broad, morphologic differential. That includes a vast array of things. I'll highlight some components. I think certainly a nerve sheath tumor is on the differential diagnosis. Typically it's quite unusual, even in the context of neurofibromatosis. Again, this is a newborn patient, so patient certainly may have a genetic predisposition, germline genetic predisposition. Even in neurofibromatosis, it's quite unusual to have congenital MPNSTs. There is a variant of cellular schwannoma that's been described as a congenital lesion that can be quite hypercellular, even mitotically active. I didn't mention, but our tumor didn't really have much mitotic activity. I'm sure some of you picked up on that as we were going through, but not much in the way of mitotic activity or necrosis, of course. DFSP, of course, can happen in children. Again, unusual as a congenital mass, but we did have some of that sort of story from architecture, the hypercellularity, the sort of hyalinized matrix in the background. And then, of course, things that tend to present as congenital lesions, infantile fibrosarcoma, myofibromatosis, certainly on differential because of the morphology, of course, but also because of their tendency to present as congenital lesions. Also, I left a conventional osteosarcoma with a fibroblastic appearance on the differential because, again, you'll remember by imaging, this is actually favored to be a primary bone lesion. Again, it's very unusual for osteosarcoma to present in a child this young. Fibrous hamartoma of infancy, I'll also sort of highlight here. We didn't see a sort of triphasic appearance, but certainly you can have overgrowth of the sort of spindle cell component of a fibrous hamartoma of infancy, and you can even have sort of sarcomas transformation in those lesions. So just some morphologic considerations. I'm sure you all have others that I did not really even raise here. I'll jump in, before we get into the discussion, I'll jump into immunohistochemistry very quickly, just as a summary of what we saw. CD34 was negative, highlighting background vasculature. Just showing you a few of the studies here. Smooth muscle actin, positive in background vasculature, again, quite negative actually in the tumor. SOX10 was negative, arguing against a peripheral nerve sheath neoplasm. And then beta-catenin by immunohistochemistry showed the cytoplasmic distribution, non-nuclear, providing no support for Wnt beta-catenin signaling activation in this tumor. So those are the images that I'll show you, but this was a panel that was performed. So a keratin cocktail, ERG was performed to roll the vascular neoplasm, MUC4 to assess for the possibility of low-grade fibromyxoid sarcoma, although overall the morphology was not quite suggestive of that. And I will show you here the Desmond myogenic muscle-specific actin in a more sort of careful way, because again, we had that interface with the background skeletal muscle. So again, we're looking at area here. We can see clearly atrophic skeletal muscle in the background, non-neoplastic. Here, the Desmond, you can see highlights those atrophic skeletal muscle fibers, I think, quite clearly. And then there is, something to debate, kind of a blush or some amount of immunoreactivity in what appears to be the background lesional spindle cells in this area of infiltration. I'll show you another image of that Desmond. Again, the background atrophic skeletal muscle fibers, sort of debatable, weak, possible immunoreactivity nearby. Same thing with muscle-specific actin, really, those atrophic muscle fibers, and then we have the appearance of some cytoplasmic immunoreactivity in the adjacent apparent spindle cells. This is a myogenin stain, sort of in a similar area. You have very pronounced, I think, nuclear staining in some what appear to be potentially aggregated or enlarged nuclei that may in fact represent those atrophic skeletal muscle fibers. And then, potentially, a touch of, maybe nuclear immunoreactivity, but overall it's not a clear signal. And another image just demonstrating kind of a similar pattern where in those areas of infiltration, you may have some staining, but no obvious result. So here's the immunohistochemistry again as a summary. And then I will go ahead and open it up for discussion. And the points I brought up, are we ready for classification? I hope you agree that this is kind of a challenging case. So perhaps not there yet, but do we have a management recommendation? Obviously, in this case, that's quite complicated by the fact that this tumor is so large that this is a newborn child who's going to grow, rapidly over many months. So huge developmental considerations for surgical management. Is there additional IHC that we would like to perform at this point, or would we jump to? Luckily, you have tissue left in the core biopsy, so are we ready to perform further molecular and cytogenetics? And I'll sort of leave it at that for now.
Okay, thank you, Dr. Grace, for your interesting case. And then we're going to continue with Dr. Linos, and then after the discussion. Please, Dr. Linos, could you please share your screen?
Yeah, one second. Do you see my screen? Do you see my screen?
Yes, it looks good, Dr. Linos.
All right, so I've done a little bit different, but I can stop if you want me before giving any stains or putting all my slides about the diagnosis. So this is a 50-year-old male who had an elbow mass, and it's a case that we had here in Dartmouth relatively recently. And I'm going to show you the core biopsy, and then I'm going to show you the excision, and then I'm not going to show you anything else then. And then I'll show you the stains and the PowerPoint that I have put together for that specific entity. So first of all, we've got a core biopsy who has some hypercellular areas and some hypocellular or possibly necrotics here from low power. Let's go a little bit high power to see what's going on. As you see here, this mass is very necrotic. And there are some hyperchromatic cells here that they look quite epithelioid with kind of eosinophilic cytoplasm. For the most part, in this core biopsy, is very necrotic. And let's keep going. Let's keep looking. There are some more hypercellular areas here. There are kind of solitary cells, but not significantly pleomorphism. But I would say quite hyperchromatic. I don't see a lot of mitotic figures here. There is some myxoid background in these areas here, and there are some kind of nucleomegaly again with a little bit of eosinophilic cytoplasm. And these here cells that look a little bit more dense. Again, we have kind of myxoid background and a lot of necrosis. Let me go to.
Dr. Nino, sorry, we cannot see the high amplification images.
Do you see that here?
No.
Let me go to the next slide to see if because I have
Yes, probably. This is.
be a lag. So this was the second core biopsy of this, and as you see here, it doesn't show a lot of the different picture from the previous one. Again, there are some hyperchromatic cells, that kind of Indian filing, if I may, but still.
Sorry, it's the same slice.
That's weird.
We cannot see the high magnification.
Do you see that now?
Okay, that's great.
So again, do you see that now, the high magnification?
Yes.
Yep. So again, a lot of hyperchromatic cells, a kind of nesting and a little bit of solitary cells. Let's go to the excision. Then we'll have the excision, and that's an elbow mass. You see kind of five radicals tissue here, and you have some very kind of well-defined nests and kind of bigger areas. So let's go see what we have here. It looks very cohesive to me in some areas. I mean, if I get that in, out of context, I mean, you think about a fully differentiated carcinoma. Again, from cleoli. And it's a little bit of mixed background here. Let's see what's going on in areas. Kind of infiltrate. I mean, this looks like breast cancer.
Yeah.
Don't forget that is in the elbow. And has kind of a lot of apoptotic bodies. It has this kind of vacuolization. That be an intracytoplasmic mucin. It looks quite blue. Let's go to some other areas. Again, it has this kind of myxoid background, but very cohesive in other areas and very epithelioid. Let me see. Another slide. I have another slide, and I will stop here, and then we can discuss, and then I can give you the stains in my PowerPoint if you like to do that, or I can go all the way through. You tell me what you want to do. So again, the background of skeletal muscle here. This is kind of very cohesive areas with single and epithelioid cells with mitotic figures and obviously malignant. There are some vacuoles, maybe, or glands. And I'll stop here, and we can discuss what will you do, or what are your thoughts, or I can go all the way. You tell me what you want to do.
So is anyone may have to do some question on some? Yes, of course, Enrique.
Hi, very nice case, Konstantinos. I think this is obviously a case with sort of epithelioid cells in a myxoid background. And of course, and there's also the vacuoles. I would like to figure out whether these vacuoles are, mucin, or maybe they are even vascular or endothelial. But my main idea would be, okay, this could be some myoepithelial lesion, maybe a myoepithelial carcinoma, or maybe I would like to figure out whether this is an extraskeletal myxoid chondrosarcoma, maybe. So I will basically go to some immunos to sort muscle tumors and muscle markers out, or muscle and epithelial markers out, and maybe some NR43 rearrangements to rule out extraskeletal myxoid chondrosarcoma.
That's a very good thought. Any other thoughts?
Yeah. I agree with Enrique's suggestion. I included also neuroendocrine markers, maybe ENSMIA1 for excluding extraskeletal chondrosarcoma. So, and maybe also we should exclude here epithelial synovial sarcoma, that this could be possibility because there is some cellular variant of epithelial synovial sarcoma that may show this epithelioid morphology. So at the beginning, maybe cytokeratin and neuroendocrine markers. And I don't know if anybody want to make a remark. Dr. Greb, do you want to say something or opinion?
Yeah, that differential sounds great. I think also felt like some of those intracytoplasmic vacuoles did have a hint of a vascular lumina. I wasn't sure if there were red blood cells in some of them, and then I also thought extracellular myxoid chondrosarcoma, and you know we have used NSM1 here, and that in our hands seems to be quite a good immunohistochemical marker to use in that context.
Well, Sylvia and Javier, please. Where was the tumor? So there is a question for Dr. Javier San Juan. What was the location? You mean, no?
I think it was soft tissue of the elbow, he said.
Yeah.
I guess we could also add some you know, epithelioid sarcoma to the differential, though. I mean, the more discohesive areas appear unusual for that, but potentially some, you know, SMARP1 or other PRC2 complex deficient tumor.
That's all really, really good thoughts, and you're spot on. But I just want to show you a little bit the thing. But before I start the things, is what I learned from Aaron Wise when I was your fellow is that we go, and that's how we approach the cases. And you can do 15 seconds up front, and actually eliminate a lot of this by combining your pre-test probability. What do you really think that this may actually be? And to go more targeted initially, and then actually you may not need to do all these stains. So what actually brainwashed me, Sharon, was do the 4-pack, and that kind of be you can twist it a little bit based on the morphology. So what she was doing, she was always doing it, right? She was doing an S100, the keratin, an SMA, and desmid for spindle. You can drop. What I'm trying to tell you is that you start very low with very few stains, relatively lineage specific stains. And once you so I wouldn't jump to a neuroendocrine marker immediately, because actually it may not be necessary at all when you get your initial screening panel. So you want to eliminate carcinoma in quotes, because obviously many sarcomas are keratin positive. Your S100 or SOC10 for melanomas can look like anything. Your desmid, just do a very, very, very brief panel, and then you can build of that panel. And you realize when you get a lot of experience with this that you actually can figure it out with very, very few stains. Or you have a really good deeper and you can immunohistochemistry. So let's do your better. And this was the keratin. Obviously, it's negative. And again, if you didn't have any history, if you were not in a soft tissue course, if you were a general pathologist or you're a pathologist in some kind of different, I mean, your first thought would be it could be proper carcinoma if you didn't pay attention to the details, like Dr. Charville mentioned. So obviously keratin is negative, but the pitfall here, and that obviously was not the case here, is that this tumor is actually can be positive quite significantly with keratin, up to 25, up to 40%, and that kind of, even very strongly and diffusely, and that actually can throw you under the bus and go to a different direction. So have to bear that in mind. This was SOX10, and that was obviously negative with some background cytoplasmic. And this was the CD34. So stains background, cell on the background vessels doesn't stain the actual tumor cell. So one other pitfall here, have to be aware when you're thinking about a vascular tumor, you really need to do 2 stains at least, because it's very common, or it can happen that you have a vascular tumor that can be negative for one and positive for the other one. So if you just do CD34, if you're screening with CD34, which is not very specific stain and stains a lot of different things, and you say, okay, stains the vessels, but it doesn't stain the tumor, you say, okay, it's not a vascular tumor, that would not be correct. So every time you think about a vascular tumor, you have to do 2 vascular markers. And the other thing is, every time you think you have keratin positivity, of course, most of the time it's going to be carcinomas in general as a statistical probability, but always have in your mind, could that be a vascular neoplasm? Because vascular neoplasms, and especially the more epithelioid they get, they can actually be multifocal, focal, or strongly and diffusely positive for keratin. So think about vascular tumors. Every time you have a keratin and you're not exactly sure if it's carcinoma, just have that at the back of your mind. This case, this was actually now ERG. It's very sensitive. We use it for endothelial differentiation mainly, but it's not specific, saying a lot of different things. One thing I want to mention, somebody mentioned sarcoma, depending on the clone that you use, the C-terminus, ERG can be or it can be positive about up to 3%. Or it can be positive in epithelial sarcomas. You have to know that. But in the appropriate clinical morphologic context, it's actually very helpful and very actually a good stain for endothelial differentiation. And this was CD31. One other pitfall I want to tell you about CD31, I don't have very, I don't have a 40X here, is one of the things I learned with Sharon is that CD31 can stain histiocytes, can stain actually significantly histiocytes, where I've seen a lot of cases with Sharon and after I finished that of pleomorphic undifferentiated sarcomas who had a lot of intertumoral histiocytes and they were brown, and people were calling them some kind of angiosarcomas. You have to have very strict criteria of what you call positive in CD31. You have to have the strong membranous positivity to consider that positive. You have this kind of granular brown positivity. It's not adequate to be absolutely certain that you're dealing with an endothelial of a neoplasm with endothelial differentiation, because it can actually stain histiocytes to a significant extent. So, but this was positive, and that was the ERG stain that we did. It was positive. So long story short, and I'm going to switch, and I'm going to show you quickly a different case, and I'm going to switch to the PowerPoint presentation. This was actually a metastatic epithelioid hemangioendothelioma from the lung. It was easy for us. We had history, and actually it was WWTR1, CAMTA1 fused. But it's a really good case, I think, because you couldn't have no history. So first of all, you have to check if there's history, because that's the cheapest way actually to make a diagnosis, and sometimes we forget to do that. So you could have no history, and it could actually be a primary epithelial hemangioendothelioma, obviously with high-risk features, and we'll talk about this a little bit, which I think is really, really nice case, because it kind of resembles carcinoma. It could have been keratin positive if you didn't pay attention to details. So always think about epithelioid vascular tumors in your differential. And I'll show you quickly this case, and I'll switch to the PowerPoint. This is a case I had very recently. This was a pelvic bone mass, which looks very epithelioid, right? Cohesive. It has some spindle cells with some extravasated red cells here. And that would be in your differential. I mean, you could think that was a bone tumor, and actually looked a little bit aggressive. Actually, it had a cortical distraction. And this case was ERG positive, and it was negative for everything else. But this case, on the contrary, it looks more uniform. It looks less atypical, and it was WWTR1 false rearranged. This, on the contrary, is a case of epithelial hemangioma, which would be in your differential of epithelial hemangioma, but obviously looks way less atypical. It looks pretty good for epithelial hemangioma, but I think it was a really good case as well. So an epithelial hemangioma versus a epithelial hemangioendothelioma. And let me switch quickly. I have prepared something for you. If you want me to do later, you tell me. I have no financial disclosures for epithelial hemangioendothelioma, right? One thing I want to mention, as I mentioned, 1/4 or even up to 40%, they can be positive for keratin. So that's a pitfall, and you can diagnose with a lot of different things. I mean, I've seen people diagnose metastatic lobular breast cancer in the skin, which was actually primary epithelial hemangioendothelioma. And obviously, not all of them will be positive. In our case, the CD34 was negative, so you need to do 2 vascular markers. And the molecular, we know for quite a few years now that the WWTR1, CAMTA1 fused in up to 90%. And there's a subset which is debatable, and we'll see what happened in the next WHO if it's going to belong to the hemangioendothelioma group. But so far, considered a subset of the hemangioendothelioma with the fusion. The good thing is, if you don't have an expensive molecular, it can take time. There's actually a very good marker. And the last few years, CAMTA1, which stains, it's very reliable, and I'll show you what the studies that we've done. It has a increased nuclear positivity, and it is a surrogate marker for WWTR1 CAMTA1. And this was the initial studies from Boston. You see up to 86% were actually positive. We see that the neoplastic have good nuclear positivity in the background of this myxohyalin. This is a classic epithelial hemangioendothelioma. And even one case, I mean, the biggest differential here is when you have an epithelial hemangioendothelioma who has high-risk fixtures that looks more atypical, has necrosis, activity, is this an epithelial angiosarcoma? And actually, the authors retrospectively, the one case that they signed out as an epithelial angiosarcoma, they actually believe that it was actually a misdiagnosed epithelial hemangioendothelioma with malignant, with high-risk fixtures. You notice I don't use the term malignant epithelial hemangioendothelioma. This term is not recommended anymore because it's a low-grade, by definition, it's a low-grade malignant vascular tumor. However, if you have more atypia, necrosis, etc., we use the term higher risk. And this was the Japanese study. It worked pretty well. A lot of other entities in the differential were negative. So it's a stain that works pretty well, that in the appropriate morphological and immunohistochemical context, you can actually drop the molecular. Here was an epithelial hemangioendothelioma from the lung and from the liver. And TFE3, the other one, TFE3 is not specific, as you know, is a member of the microphthalmia family of transcription factors. And although it's natively ubiquitously expressed in humans, it's not actually detected by immunohistochemical method. You have to be very careful with TFE3 because it's a difficult antibody, and to be a truly surrogate marker for the underlying TFE3 fusion, you need to see diffuse, strong nuclear positivity. If you see a little bit here and there, it's not very predictive of the underlying fusion. Of course, not specific. A lot of different things. The most recent ossifying fibromyxoid tumor. So a lot of different things can be TFE3 fused. And the subset that I told you, the YAP1 TFE3, looks different as vasoformative. You're never going to see a classic epithelial hemangioendothelioma that vasoformative. Because the classic epithelial hemangioendotheliomas are primitive endothelial differentiation. They have these intracytoplasmic vacuoles, but they're not going to see very good vasoformative, but you see that in the YAP1 TFE3. Here another example, I have this very eosinophilic cytoplasm, and of course TFE3 positive and CAMTA1 negative. But the story is not that simple. The story is never simple. There are actually genuine cases of epithelial hemangioendotheliomas. There are not many. There was one good paper from Korea that actually had both TFP3 translocation with expression of protein and CAMTA1 rearrangement. So the story is not, seems very rare, but the story is not black and white. The new thing is you have to be aware there are variants of epithelial hemangioengliomas that they don't have the CAMTA1 as a partner. So if you do actually the stain, the CAMTA1 is going to be predictably negative. So it's not 100% sensitive. There are other partners recently described, and for some reason, for now, they show a propensity for cardiac involvement. That may stand the test of time or may not. But you have to be aware that if you just apply immunohistochemistry for these kind of cases, you're going to miss it. You have to do molecular. They're very rare. And the new thing, there's a new paper a few months ago from Christina Antonescu Memorial Sloan Kettering that to do what is the prognostic stratification. And the solitary soft tissue epithelial hemangioengliomas, they're actually doing pretty well. But people who had pleural involvement, lung epithelial hemangioengliomas, or the ones that have metastasis, obviously they behave more aggressively. And seems like, although the initial paper of the YAP1 TFP3 suggested that it may actually be an aggressive, it actually seems like the opposite, that the YAP1 TFP3 may actually be less aggressive from the data that we have so far. So may actually not may be separated from the classic epithelial hemangioenglioma, but in any way seems to be behaving in a more indolent fashion. The cutaneous ones are actually very, very indolent. And then, the new paper last month in the American Journal of Search Path, people looked about risk stratification and they did a new proposal for risk stratification. And they found that actually tumors that they are more than 3 centimeters and they have more than 1 mitosis per 10, and they show high-grade nuclear features, they behave actually more aggressively. So they were kind of high risk. So they kind of proposed a new stratification system with tumor size, histology, and then put it in category. And what they discovered, that's pretty interesting, that actually they had a small subset of cases, they all were high risk, they all look kind of malignant, they have nuclear atypia, etc., and behave aggressively, and they were synaptophysin positive. So it may be that a subset of epithelial hemangioengliomas which are synaptophysin positive and show high risk features may actually behave quite aggressively. And this is interesting because the same thing has been seen in composite hemangioengliomas, that ones with synaptophysin positive, they can actually be more aggressive. This is my email if you want to contact me, and I only tweet for work. And the last thing I'm going to mention is we have an international health fund here in Dartmouth that we actually do consultations from abroad for free. Our interpretation, ancillary studies, molecular studies, whatever needs to be done, we issue a report and then we send you the slides back. That's a free service. We don't charge for abroad, and we're happy to see if you have any interesting cases, or if you want a second opinion, or if you want to further collaborate in research. And I'll stop here. Thank you very much.
Thank you very much for your presentation. And I have checked in the chat box, and just to say that Sylvia has proposed epithelioid hemangioendothelioma when you present the case, so just to say that. And this is very interesting, the neuroendocrine positivity for this tumor. And there is some people that asking about AIND1, a smart CV1 in this tumor. This is already explored?
I didn't want to.
Yeah. So I have a question now for Dr. Grebs about this case. And please, everybody may have question or directly or by the chat box. Let me know, and you can say directly the question by mute your phones. So, Dr. Grebs, I would like to know about the immunohistochemistry result of your case. And I wonder about the NTRAT immunohistochemistry. I don't know if you have shown, but no, I'm curious about NTRAT immunohistochemistry result of this case.
Yeah, and sorry, I didn't describe fully, but most of these other, aside from the ones that I described, were clearly negative in the tumor. The pan-track immunohistochemistry indeed was negative for immunoreactivity. In our hands, we do occasionally see, the antibody can be, somewhat difficult to use. In some cases, we do see kind of a blush of immunoreactivity that's difficult to interpret in some cases, but sort of as a screening tool, we think it's quite useful, as many groups have published. But it was negative in this case. I think it's a good hypothesis. Obviously, whenever we see a bland spindle cell neoplasm, particularly in a child, we're thinking about obviously NTRK related fusion neoplasms, but also now has been described, as many of you know, many other kinases translocated in similar appearing tumors. Again, I'll highlight, oftentimes we see CD34 and or S100 immunoreactivity in those tumors, but not always. Certainly, we've had NTRK and other kinase rearranged sarcomas that do not express CD34 or S100. So I think it's, that remains, I think, kind of on the differential diagnosis at where we stand right now.
Yeah.
How extensive is the NGS panel? Will cover NCOA2 and VGLL2 and things like that?
So the an NGS panel that we would run would we do have a fusion targeted NGS panel here that includes NTRK 1, 2, 3. It actually does not include VGL2, but it does include NCOA2. So that would be an option in this case. And I'm seeing Sylvia mentioned myofibroblastic sarcoma, certainly low-grade myofibroblastic sarcoma on the differential. I think that's a great, obviously this, that you'd like to see some smooth muscle actin expression in a myofibroblastic sarcoma, but of course nothing, I also would not exclude that at this point. So I think that's a great point. Obviously with the fairly low-grade features, we would consider, myofibroma. It may be difficult in this context to distinguish those two, especially in a congenital tumor like this.
Okay.
So I'll move on. So one of the considerations we had was in sorting out, again, that desmin and myogenin that seem to appear at the interface, that sort of blush of desmin. We did perform a MyoD1 stain, again, in our hands, somewhat messier, if you will, in the sense that there's more cytoplasmic immunoreactivity. But it did appear that there were, again, some of these lesional spindle cells potentially, albeit in an area of interface with background atrophic skeletal muscle, that may have had some, nuclear immunoreactivity. Again, admittedly difficult to interpret. I think at the bottom of the screen you may see another cell. And again, it's difficult to say for sure that does not represent background staining. Here we do a stain PAC7, which is non-specific in this context, but certainly is expressed in tumors with rhabdomyoblastic differentiation, along with synovial sarcoma, along with Ewing sarcoma. So again, not specific, but in this context, it did make us think that potentially some of the evidence of skeletal muscle differentiation in the tumor itself, the myogenin I described earlier, the desmin, the muscle-specific actin, was truly representative of myogenic differentiation. So in fact, we were most concerned with that result, that this actually represented a spindle cell rhabdomyosarcoma, and in particular, a congenital variant of spindle cell rhabdomyosarcoma that was described in this 2016 paper, again from the Sloan Kettering group. In particular, they found recurrent fusions in 10 of 11 of these congenital type spindle cell rhabdomyosarcomas. Dr. Linos' question sort of hints at the rearrangements that are present in these, VGL2 commonly involved, NCOA2 commonly involved in these tumors. Again, 10 of 11 of the tumors that were analyzed in this study actually had these fusions listed here. So in our case, we actually did sign this out as a rhabdomyosarcoma in favor that it represented the spindle cell variant, a congenital variant. We did, just as Dr. Linos suggested, we actually pursued our fusion targeted sequencing panel. And I'll point out here, as I mentioned, even though it does not have VGL2, and at this point, actually, we did like this panel because it did still evaluate NTRK. It evaluated things like FUS, other things on the differential that would still be excluded with this panel. It did include NCOA2, which is one of the partners that is recurrently rearranged in in spindle cell rhabdomyosarcoma, congenital type spindle cell rhabdomyosarcoma. And indeed, we actually found a VGLL2 NCOA2 fusion in this tumor, supporting the diagnosis of a congenital type spindle cell rhabdomyosarcoma. I'll point out from this 2016 paper, it was quite interesting. All of the patients with this congenital type tumor were treated with adjuvant chemotherapy, and actually all of them did quite well. They were alive and well, some with quite long-term follow-up, many years of follow-up, and none of them demonstrated metastatic disease. That's in contrast to older children and adults, and some of you may have experience with this tumor, I think, that more often exhibit this MyoD1 mutant variant of spindle cell rhabdomyosarcoma, often exhibit diffuse MyoD1 immunoreactivity by IHC, and those typically have aggressive clinical behavior. So we pursued the molecular in this case in part because there is an important sort of clinical behavior distinction in these molecular subsets of spindle cell rhabdomyosarcoma that, of course, the WHO classification now recognizes. And I thought this case was interesting in part because there's a very recent paper here from a large group, collaborative group, that described 4 cases of these infantile congenital type rhabdomyosarcomas with these exact same rearrangements involving VGL2 that actually behaved aggressively. So in contrast to what we thought about these tumors, in fact, I signed out the case that we're discussing now with a comment that said that typically these tumors behave quite favorably. But this paper kind of turned that concept on its head. And I want to highlight what they found. Actually, 3 of the tumors, much like our case, exhibited bland morphology and actually were initially diagnosed as fibromatosis or infantile fibrosarcoma. So 2 of the cases diagnosed as fibromatosis, 1 is infantile fibrosarcoma. And actually the 4th case was high grade appearing at presentation. So I think it highlights the challenge in making this diagnosis and the pitfall in classifying it as something low grade or even benign. The low grade tumors I want to highlight, just like our case, only demonstrate only very focal positivity for desmin myogenin or MyoD1. So when encountering a spindle cell neoplasm with bland morphology and rhabdomyosarcoma, spindle cell rhabdomyosarcoma is on the differential, it's certainly very important to analyze very carefully these skeletal muscle markers by immunohistochemistry, desmin myogenin, MyoD1. We tell the trainees here at Stanford that once you order these studies, you have to really look at them quite carefully to look for that nuclear immunoreactivity. And this paper suggests that the aggressive behavior sort of coincides with morphologic evolution to high-grade sarcoma. So unfortunately, some of these tumors, there was either delay in treatment with adjuvant chemotherapy, or they were not treated with adjuvant chemotherapy, and that may have actually contributed to a sort of transformation over time of these tumors. So it suggests that these are sort of tumors with intermediate biologic potential that can evolve into high-grade tumors. So that's all I have for you. Hopefully you appreciate the case, and thanks again. And hopefully this is again the first of a lot of collaborative interactions with the group. Any questions or thoughts about that case?
Well, that was a great case.
Sorry, what was that?
That was a great case.
Oh, thank you. Thanks.
Great. I have a question relating to PAX7. So
yeah,
you know that this is very difficult to have internal control positive in a tumor, like in KX2.2 for Ewing sarcoma.
Yeah.
So how are you dealing in your routine daily when a case is negative for PAX7? Do you use external positive control?
That's right. Yeah, we have yeah, that's a great question. And I'll just repeat it for the group. The question is, how do we deal with the issue of control with immunohistochemistry, because internal control is often absent with PAX7. We do have an external on-slide positive control. Ewing sarcoma actually we use, as I mentioned, is to express in Ewing sarcoma. So we actually have that as the external positive control. I'll also just simply mention that it happens to be a technically very sound antibody, so it's quite it's quite reliable. But yeah, we have external positive control on slide.
Yeah, it's the same experience. It works pretty well. I mean, it's not very specific, but it works. It's very robust. One thing I mentioned about your question, I suspect why is this question? I've seen a lot of cases from Europe that don't have external control in the slides, where they kind of rely on the internal control for most of the part. I don't know how it's done in Spain, but US, it's a requirement. You can't get approval. You can't get when you get inspected. You really have to have external control in every single immuno that you order, irrespectively of the internal control. It's part of their certification requirement.
Yes. So there is a question in the chat box. In the daily routine to make a diagnosis, so you can read this. It's for Dr. Linos, I guess, or for Dr. Guest, whenever you want to answer.
I want to answer about the previous question. There's any experience with BCL2 and epithelial hemangioglioma? I just want to mention two things. Let me see how to say it. I don't want to sound like two stains that I have ever used in my career as pathology is Vimentin and BCL2. I've never used these stains, but people use it. But I'll tell you, never use Vimentin. Throw it on the bin of history. It's not helpful. And BCL2, I don't recall a single entity that could be helpful in soft tissue pathology. It's very non-specific stuff. Don't use it. Start very low with lineage-specific stains, 3-4 stains, and then build from there. But I would say BCL2, if you're dealing with soft tissue tumors, do not use it, or Vimentin. In terms of epithelial angiosarcoma and epithelial hemangioglioma, I don't think this would be clear. I mean, I love molecular, but I don't use them because I'm curious or. We use it for research setting if we want to discover new partners, etc. But in everyday practice, we use it when we think it's going to be actually helpful. So in many times, epithelial hemangioglioma versus epithelial angiosarcoma, you can easily do that distinction. The problem is, as I told you, epithelial hemangioglioma when it has high-risk features with epithelial angiosarcoma. Although even in these cases, epithelial angiosarcoma actually looks more atypical, but there are cases that can be very difficult. I mean, you can skip the molecular if you have the CAMTA1 in 95% of the cases, 97% of the cases. You actually can make the diagnosis with that stain. But if you want to do molecular, then you have to do an NGS that will cover your fusions, your CAMTA1 or the WWTR1 fusion to catch it. So you have to do NGS. Epithelial angiosarcomas, they're not translocation associated sarcomas. They have more complicated genome, where the translocation associated sarcomas, they have more quieter genome because the fusion is enough to give all the hallmarks of cancer and develop the tumor.
So I have another question for both. So it is pretty obvious that molecular biology analysis recently will improve the skill for pathology, maybe to analyze the morphology. But what do you think about this promiscuity of gene fusion in soft tissue sarcoma? Does this could be danger or may cause some skepticism or problem about the gold standard of molecular biology for the diagnosis of soft tissue sarcoma?
Yeah, I think it's a great point. I think, perhaps it would not be too hard for this group to find agreement on the fact that, we have to review that molecular biology in the context of all the other findings, right? I think Dr. Linos's case and examples sort of drive that point home, because now we know that, these fusions are present in various forms in, we have, for instance, EHEs, epithelial hemangioendotheliomas that have both WTR1 and TFE3, rearrangements. So as an example of the complexity. So I think, yeah, I would certainly sign on to, and I imagine most soft tissue pathologists would sign on to the notion that you have to view it all in context and probably don't make a diagnosis based on the molecular alone, despite the huge utility of those types of studies.
Okay, thank you.
Totally agree with that. Everything starts for morphology, and then everything has its ancillary studies. So everything starts morphology, and you go all the way back to morphology. So it can be helpful, but you have to interpret it in context of the morphological context and the clinical context. But what I think is going to happen, and I see that sometimes in my practice, I do that. I mean, in some cases, when I feel very strongly for morphology, what it is, I'm not gonna bother, because the NGS becomes so cheap and cheap and cheap every month by month. If I see something that says it's got to be synovial sarcoma, I mean, you could say, okay, you can do a couple of things and sign it out. That's fine. But let's say if I want to confirm it, and I'm really, my pre-test probability is so high, I may actually jump directly to molecular and see what I expect, and then just drop the immunos. And that, I suspect that actually may happen. You may actually do a lot less immunos and go directly to molecular, which actually is going to be very soon as expensive as one immuno. But that's going to happen pretty fast. But then you have to put everything in context, right? Because then the molecular data will be like an immuno. You know, it's not going to be super specific. They're going to be different entities with the same fusion. But if you actually put it together with the morphology, it actually can be very helpful.
Okay, thank you. And following with this question, what are your opinion about the next generation immunohistochemistry? So this is antibody that surrogate these molecular studies.
Maybe I'll defer to Dr. Linos. I'm a bit biased in having a sort of a vested interest in that area of research. You know, I mean, I think it's yeah. I mean, I think, you know, beginning with obviously Dr. Galva's on the call, well known for his work on Ewing sarcoma. I mean, beginning with Ewing sarcoma, and even before that, desmoplastic small round cell tumor. I think it's proven its utility, again, in the appropriate context, to serve as a surrogate that can make these diagnoses more efficient, whether that's reducing the time, reducing the cost, depending on the resources available to us at a given institution, if NGS is not available. But I think it certainly has its utility in particularly detecting recurrent fusion oncoproteins that are overexpressed in tumors. W2TR1 CAMP1 being a perfect example of its utility, where I think we could use that in lieu of a molecular study in many cases of epithelial hemangioendothelioma.
Okay.
Yeah, a great question. I mean, the immuno changes, and it's not now. You have the CAMT1 is the marker for the partner, but then you have the new immunos, let's say for synovial sarcoma, that actually for the fusion protein, and that's actually great. They work pretty well. And actually, you can skip molecular if you actually have this antibody. There are not that many so far.
Yeah.
But I still think that it is a step that is actually we're somewhere in the middle. I mean, very soon, molecular will be so fast and so cheap that I'm not sure if we're going to practice the same way we're practicing, let's say in 2035 or 2000. I'm not convinced. It's becoming they go so fast that I think it's going to be, they have 2 weeks turnaround time. It's not going to be true for much longer.
Okay. So if anyone have any question, please. Nobody? Okay, thank you very much for your both presentation. We really enjoyed both presentations, and that was very nice. And same for to be part of this international session that I think will help to improve our knowledge about sarcoma, listening pathology overseas, about how they approach the sarcoma. That was very interesting. Hopefully, we will see you in the next future, in the next session. I will invite you by the link in the other session. If you want, or if you have time, you may join us. For us, it was a pleasure to be with you today. And thank you. If anybody have any other question, we close now the session.
Thank you, Dr. Machado, for organizing this. This was fantastic. Thank you.
Thank you for your participation.
Thank you.
Okay, thank you. Ciao.